going to pick up with genitourinary, and so this will actually be continuation of part 3. Newborns, like anything about them, they have immature kidneys, and so their kidneys have to kind of get started, jump start, and begin to function. On this particular slide, the weight loss, and there may be a change here from your PowerPoint, but weight loss is typically acceptable 5% to 10% during the first week of life. Babies usually lose down from their birth weight. We do daily weights in the hospital. As a lactation consultant, we're very concerned about a baby that has, prior to discharge, which is usually 2 to 3 days, has a 10% weight loss or greater. We've got to have a plan of action for those breastfed babies to supplement or to add in some extra formula until the breast milk comes in fully, because we don't want them to lose down past that 10%. Most babies do very well, and especially breast babies, about gaining back that amount. Usually by 2 weeks out, and when they go back for a pediatrician check, they will have gained back to their birth weight, if not more. But in the hospital, daily weights are done. If a baby's sick and has an IV, we do INOs, like strict INOs, where the diapers are weighed. But if you have a normal newborn with no abnormalities, no complications with the GU tract, or nothing that you know of, then we would just count wet diapers. And we give the mother a diaper diary many times, and they keep up with wets and stools. And the mothers, sometimes as lay people, we call them poops and peas, and so they will document each time the baby voids and each time they have a stool. We always want to warn mothers about that we do want the infant to void within the first 24 hours, and we also would like to have a meconium stool pass within the first 24 hours. Only babies that we have concerns over the genitourinary tract, concerns about the kidneys, or there's abnormal labs that have come back, or the infant is sick. It's not a typical everyday thing to measure specific gravity, but you do need to monitor all babies for signs of dehydration. And it's going to be the same things that you would do for an adult. The only thing that's different is in an infant, the fontanelles are the place that we look for dehydration. If the anterior fontanelle is sunken, if the eyes are sunken, the skin is very dry, mucous membranes are dry, those are all signs of dehydration, and the fact that the baby is not voiding. And that's about all about the GU tract. If there are questions about chromosomal issues, they will do an ultrasound to make sure that both kidneys are present and that they're functioning, that there's actually urine in them and being produced. We will want to force some fluids and all if the baby is at the 24-hour point or near that and has not voided. When we're talking about GU, you're talking about, you're thinking about externally looking at the genitalia, making sure that, and that's done initially at birth. It's either a male or a female. If there's ambiguous genitalia, then you've got a problem, and they may have to do chromosomal studies, and there's kind of a complication there with putting a hold on, is it a blue bow or is it a pink bow, and what's going on, and so the physician would step in at that point. You're also looking at the abdomen. The abdomen should be round and soft without any palpable masses. We've talked about 3 vessels in the cord, ava, 2 arteries and a vein. Bowel sounds should be present on an infant within an hour or so after delivery. We want a first void within 24 hours, and that first urine that comes out, it's called, I don't see it very often, but some parents note it and they're concerned about it. You can look on the diaper, and it's called red brick urine, and it's just where it looks rusty and stained from uric acid crystals that are in it. So it's not uncommon for the very first to be kind of sludgy and have some crystals in it and look kind of rusty or red looking. And so that would scare a parent. They think it's bloody and there's something wrong. But that is a normal occurrence. Kind of concentrated looking. Meconium stew should be passed within 24 hours. You're looking at the female genitalia. The labia majora should cover the minora, and this depends on how mature the female infant is and the gestational age, and that is part of the gestational aging, is to look at both male and female genitalia. If the labia majora covers the minora and the clitoris, then the baby's very mature. The more opened up it is, the more premature. Male genitalia, we want to make sure that we check the penis and see that the urinary meatus is at the tip of the glands, that it's in the center, that it is not hypospadias or epispadias, that it is not off-center, and that will produce problems with doing a circumcision if the parents desired a circumcision. Is if the urinary meatus is not in the center, they may have to use that foreskin to do the repair for an epispadias or hypospadias infant. So they would delay the circumcision until after they did the revisions or corrected the urinary meatus. The testes should be descended in a mature or full-term male. They should not be up in the inguinal canal. They should be down in the scrotum, and the scrotum should have rugae, or the crinkling and the indentations in it. The deeper the rugae, the more mature the infant is. And also, usually, the more pendulous the scrotum is. And so that's about all on the GU. Circumcision. By definition, I mean it's a congenital removal of the foreskin of the penis. The rationale for doing this, some people it's a religious conviction and actually a religious ceremony that takes place. And for others, they're concerned about the children later, the males not being able to have proper hygiene or clean pull back, retract the foreskin and clean the penis. And others, for most people, it is a cultural and social norm to have this either done or not done. Right now, the Academy of Pediatrics says that it is unnecessary to do circumcisions, that male children should be able to be taught to retract the foreskin and clean around that area, that should be part of their daily hygiene and bathing process. That it is for cosmetic purposes, and that it is not, medically necessary to do. And years ago, we did circumcisions with no pain relief, no anesthesia, and most of the time now, it is recognized now that it is a painful procedure, and that physicians will either do a lidocaine block, a regional block, which I feel like is the best form of anesthetic to just block and numb that area, they can use EMLA cream. And you need to look at lidocaine, and some of you have gotten to observe and see circumcisions that are done with a lidocaine block. It works very effectively for the procedure, and then when it wears off, the child will, feel discomfort. Post-circumcision, but the topical anesthetics like EMLA cream, the EMLA has to be put on with a tegaderm dress, and it needs to be left on at least 20 to 30 minutes for it to be effective. The other things that we do are comfort measures for the baby. Sucking is a form of pain relief for the baby. It's the only way they know to soothe themselves. So sucking on a gloved finger of the nurse while the procedure is taking place, or on a pacifier if they're not breastfeeding. Also giving the baby what's called sweeties or glucose water, sucrose. It can work as an endorphin. It's the same reason we like chocolate and candy and sugar as a comfort food or comfort measure, but it produces endorphins in a baby, and actually works like pain medication, like a morphine or something, as in giving it to them. You will give very small amounts in their mouth after they're strapped down to the papoose board. You could do it before. You have to be very concerned about small amounts to prevent aspiration. It can be absorbed buccally and in the cheeks of the mouth. Some doctors don't like it, and I have seen many babies after the procedure, the sweeties or the sucrose will cause them to have nausea and vomiting, or they will spit up and throw up a lot. And so then your concern is you've really got to be right there watching them, which the nurse is that's assisting with this, so that you prevent any aspiration. So you would need a bulb syringe. You need to know how to use it. You need to have that available. But usually the spitting and the vomiting would occur after the procedure's over. It could cause that. Okay. Complications to a circumcision would be infection, and that would come later. Your initial complication could be hemorrhage. We look at hemorrhage immediately. We're checking for any bleeding and assess the baby's vital signs, and kind of you're assessing for pain also. But your biggest complications are pain and hemorrhage right away, and then infection. And that could occur several days later, even after discharge of the infant. So you also want to monitor the infant for voiding. If the circ is done on the day of discharge, then you would have, tell the mother that the infant should void within so many hours, or you would be concerned if the baby went more than 8 hours. Hopefully the infant will void within that 8-hour period, but if you've had a circumcision done, you could understand the trauma in that area, why it would, the infant would not want to void, or that it might not occur. And infants do not eat and nurse well after a circumcision, especially breastfed babies, but even bottle-fed babies. They want to suck and do non-nutritive sucking, but they don't nurse or eat very well because they've been through trauma. As soon as we can, after our assessment and our checking for bleeding and assessing their pain scale and all post-circumcision, we try to get them back to their mother as soon as possible, so that she can, and we do swaddle them and we comfort them as nurses, but we want to get them back to mom because she's concerned about them being absent from her room and from her but we want to get them back so she can, can swaddle and feed and comfort the baby. They're usually very fussy. Plastibell, there are several ways to do circumcisions, and Plastibell is one, and it usually falls off within about the same length of time that it takes the cord to fall off, so anywhere from 4 to 10 days. It's typical like 7 to 10 days. 4 to me would be kind of early for it to heal and fall off, so about 7 to 10 days. And if it stays on longer than that, and it's not healing and falling off, then the pediatrician should be notified. Most people don't know that the mother's obstetrician is typically the one that does the circumcision. It's not to say that pediatricians cannot, and some of them do, but the physician that does it needs to have knowledge of suturing and ability to correct anything that might go wrong. If more was cut off, or if than needed to be, and there needed to be sutures placed, it's just that your OBGYN is typically a surgeon and capable of doing C-sections, and so they deal more with stopping the bleeding if the infant is hemorrhaging. And male infants, we don't know, who is going to be a bleeder and who isn't. So that's something that, can happen, if they can, bleed profusely from the circumcision. And so there are things that we apply to the circumcision. They can cauterize it. They can use silver nitrate sticks to cauterize and stop the bleeding if that occurs. But most of the time you want the surgeon. And the pediatrician then, if the obstetrician did the circumcision in the hospital, the pediatrician follows through and answers questions about it, or will, take care of the child once it's been done. You have to have written consent signed by the parents and the mother. And you do a timeout anytime you do an invasive procedure like this. You do a timeout, and the physicians will stop. They will match bracelet numbers. They will identify the baby. And this is a new procedure at most hospitals for any type of, it's not a timeout to say which limb. That would be done in surgery, but it is, a timeout to identify and make sure you have consent forms, that everything is signed, that the parents really want this procedure done, because there's no going back and replacing the foreskin once it's been taken off, so you need consent forms. The physician should have talked to the parents about any questions or any risk factors ahead of time regarding the circumcision. And so the timeout includes the right baby, the right procedure, that there are consents there, and making sure that you do check the armbands for proper identification. So this is done with the nurse that's assisting. And the nurse is also responsible for setting up the sterile field, getting the, knowing what the doctor prefers, like lidocaine block, and getting the medication and the field set up, the right size gloves and all. And so she prepares everything, and most of them, they have a list and they know which doctors use which method of circumcision equipment that they need, whether they do the Plastibell, Gomco, or Mogan clamp. And this just shows a papoose board, proper positioning of the infant for circumcision, restraint. And so this baby's swaddled, but it's also strapped. The legs are strapped. And at most hospitals, they don't use just the swaddling method for the upper extremities, because that ties up the nurse with holding. She cannot leave the baby, and what if she has to give the sweeties, or if she has to move and get the physician something. So we strap the arms down also. There is a diaper under here, and we just, expose the infant. In this case, most places that I have assisted and helped with SUSCC, there is a heated warmer, there's a light above the baby, and it not only produces light for the procedure, but it has a heater in it, and it keeps the infant warm because they are undressed and exposed. And the biggest thing that makes them anxious and mad and upset and crying is the fact that they don't like, most babies, healthy babies, are flexed, and they like to stay flexed in that scrunched up fetal position. They don't like to be stretched out and strapped down, and they feel, I'm sure, very vulnerable, and that makes them anxious and fearful. And so our job is to, like the nurses do, and to swaddle or try to support and let the baby suck, non-nutritive sucking, to soothe them and relieve their anxiety. This is a Gomco clamp. This part is metal, and it's placed, there's usually an incision made here, a slit made here. They place this over, this bell over the head of the penis, so as not to make any mistakes and do any damage to the head of the penis. And at this point, a clamp will be placed around this, and this is the foreskin that will be, the extra skin that's pulled up around it will be cut off. So the bell here, this clamp, this screw is tightened down, and it actually, there's a ring around here. It puts traction on this. It supposedly makes for a bloodless circumcision, so it cuts off the bleeders and kind of crimps and cuts off any bleeders, and then the scalpel or the knife blade is taken and you remove, the physician removes the excess foreskin. Plastibell, this is just the handle. This actually goes over the head of the penis, and a string is tied around it, and the string is what cuts through and makes the indentation. And after about 7 to 10 days, it's gonna, the plastibell, this part, will heal and fall off. The only problem with that is parents, you get more calls back from parents, because many times that there will be just, it'll be hanging on, the plastibell will be hanging on by just a tag of skin, and it'll cause a drop of blood, and the parents panic and say, it's bleeding, do I pull it off, it's just hanging there. And what you want is for it to fall off, heal and fall off on its own in the diaper. For definitely the parents not to go ahead and pull it off if it's not healed enough for it to detach on its own. Okay, parent teaching. You want to teach them to keep the area clean and dry. Right immediately after a circumcision, the parents need to, and the nurses too, to apply the diapers very snugly and tightly to, compress that area and hopefully, decrease any bleeding. On the Gomco and the Mogan methods, there will be Vaseline gauze placed around the penis after the circumcision. Naturally, the plastibell covers, and there's no Vaseline needed on this type of procedure. So care is done a little bit differently, but we place the diaper on there, and on the Gomco and the Mogan methods where there's no plastibell, you will have a Vaseline gauze around it, and you want that's also to protect and to decrease the bleeding around it to help with healing, but it also keeps the penis from sticking to the diaper. And the Vaseline repels any urine, hopefully, because of its the oiliness and all. It'll help repel. You want to change the diapers frequently to keep from urine sitting on that raw area. You just wash the genitalia with warm water, no soap to it until it's healed. Just clean it off with warm water. Do not use wipes, because the commercial wipes, because they contain alcohol, and they can be very irritating to the wound and very painful. The baby will be screaming. The yellow crust that forms on the wound should not be removed, and this is something that usually occurs several days out. You'll see the yellow crust, and it's called granulation tissue. It's just like any wound granulating over, and it'll be a yellow crust. It's not oozing. It is not purulent, smelly drainage. It is a yellow crust, but parents will call about it and not understand that yellow exudate is normal, and it's part of the healing process. It should not be wiped or washed off. That the penis is trying to, and the circumcision is trying to heal. Check that the infant has at least 6 wet diapers per day, and check for bleeding about every 15 minutes for the first hour, then about every 30 minutes for the next couple of hours. And we usually take the baby's own out and tell the mother when they change the diaper if there's any increase, any bleeding, or if she's concerned about anything, to call us, and they will definitely call. If you are having problems with bleeding, we usually do the diaper very securely on the baby. But some people say that you need to apply it loosely to prevent it from causing pressure on the circumcised area. So there's differences in feelings about how to care for, as far as how secure to put the diaper after delivery. After circumcision. But if you're putting Vaseline around it, then hopefully it's not going to stick to the diaper, and that's one of our main concerns. Gastrointestinal system, I've already talked some about that, about assessing the abdomen. Newborns are able to digest simple carbohydrates, but unable to digest fats due to the lack of lipase. And so proteins may be only partially broken down. So hello? Hey, what you doing? I'm still at work. Where are you? At home. Where are you going?